This is Lecture 6C, Somatosensory System. Somatosensation is defined as the physical experiences of pain, temperature, touch, and proprioception. Somatosensation begins with localized receptors in skin, muscles, joints, and blood vessels, and ends in the sensory cortex of the parietal lobe. There are different types of sensation, including mechanoreception, thermoreception, and nociception. Mechanoreception includes touch, which is both localizable and diffuse or unlocalizable, pressure, vibration, and kinesthesia. Thermoreception includes the sensation of hot or cold, and nociception is the sensation of pain. There are specialized receptors for touch, vibration, pain, and temperature. Encapsulated endings are present in the subcutaneous tissues, skin, fingertips, palms, lips, and external genitals. Encapsulated endings mediate fine discriminative touch and vibration. Free nerve endings are present throughout the body, subcutaneous tissues, skin, and visceral organs, and these mediate pain, temperature, and some tactile sensation. Expanded nerve endings are present in the dermis and joints, and these mediate touch, temperature, and pressure. The somatosensory system is a 3-neuron organizational system. First-order neurons include cell bodies in the spinal dorsal root ganglion. First-order neurons collect information from the periphery and transmit this information to second-order neurons. Second-order neurons are present in the spinal cord or brainstem. Fibers cross midline and descend to the contralateral thalamus. Third-order neurons project from the thalamus to the primary sensory cortex in the parietal lobe. This diagram illustrates the 3-neuron organizational system. The first-order neuron, again, is at the dorsal root ganglion. The second-order neuron is present in the brainstem and spinal cord. There's decussation of fibers, which progress to the thalamus, and the third-order neuron and projections then extend to the parietal lobe, to the somatosensory cortex. The innervation pattern of the somatosensory system is a mixed organization of spinal sensory pathways. These include discriminative touch pathways, pain, temperature, and diffuse touch pathways. Mediation of discriminative touch is through axons, which ascend on the ipsilateral side of input with decussation at the level of the medulla. Mediation of pain, temperature, and diffuse touch are through fibers with immediate and multiple crossings in the spinal cord. Spinal lesions can result in the loss of discriminative touch on the ipsilateral side, as well as loss of pain and temperature on the contralateral side. As a reminder from prior lectures, we know that each spinal nerve has a dorsal root and a ventral root. The dorsal root carries sensory information, so this would include our general somatic afferents and general visceral afferents. The ventral root carries motor information, and this includes general somatic efferents and general visceral efferents. An additional reminder is that there are 4 motor tracts in the spinal cord. So you remember the lateral corticospinal tract, which originates in the motor cortex of the frontal lobe. This tract decussates in the lower medulla, spinal cord junction, and is responsible for contralateral movement of the body. The anterior corticospinal tract originates in the motor and premotor areas of the frontal lobe and courses ipsilaterally and is responsible for trunk muscles. The rubrospinal tract originates in the midbrain, decussates, and modulates flexor tone in the upper extremities. The lateral vestibulospinal tract originates in the medulla, courses ipsilaterally, and controls extensor tone. The sensory tracts include the dorsal columns and the spinothalamic tract. The dorsal columns include fasciculus gracilis and fasciculus cuneatus. These relay fine and discriminative touch, pressure, and proprioceptive sensory information to the thalamus and then the sensory cortex. The spinothalamic tract ascends through the spinal cord to the brainstem and the thalamus, and then finally to the sensory cortex to relay pain, temperature, and touch. The dorsal column medial lemniscal system mediates discriminative touch, vibration, limb position, kinesthesia, and proprioception. The anterior lateral system includes the lateral spinothalamic tract and the anterior spinothalamic tract. The former mediates pain and temperature, the latter mediates diffuse or non-localized touch. And this schematic shows the location of the dorsal column medial lemniscal system and the anterior lateral system. And this schematic shows the same systems. The dorsal column medial lemniscal system, again, mediates discriminative touch, vibration, limb position, kinesthesia, and proprioception. And then just as a reminder, this is a 3-neuron system of organization beginning at the dorsal root ganglion and ending in the parietal lobe. Deficits that are seen in association with dorsal column medial lemniscal system lesions would include peripheral nerve injury resulting in widespread sensory loss, a lesion of the spinal dorsal column resulting in ipsilateral loss of sensation below the level of the lesion, a lesion affecting the arcuate fibers that would result in a contralateral sensory loss, a spinal cord lesion which would result in sensory loss as well as motor function impairment below the level of the injury, and then a lesion of the primary or somatosensory areas causing sensory loss, cognitive impairments, and tactile agnosia. A lesion of the primary sensory cortex, which includes Brodmann's areas 3, 1, and 2, would result in a loss of sensation. A lesion of the somatic association cortex, which includes Brodmann's areas 5 and 7, which is the superior and part of the inferior parietal lobule, would result in cognitive impairments and disorders of cross-modality integration. Examples here include tactile agnosia and neglect. We can assess deficits of the dorsal column medial lemniscal system by examining patients using 2-point discrimination, the use of a tuning fork to assess vibratory sense, identification of objects through touch without visual input, identification of numbers and letters traced on the skin, the Romberg test, and then finally moving an individual's arms, or fingers into particular positions and then asking patients to report or replicate those positions. The anterior lateral system includes the lateral spinothalamic tract, which mediates pain and temperature. And again, this is a 3 neuron system. Damage to spinothalamic fibers result in an alteration in terms of perception of pain and temperature. A pinched nerve root results in pain at the compromised neural level. A spinal cord lesion affecting the lateral spinothalamic system results in syringomyelia, in which pain and temperature sensation are affected on the contralateral side. A brainstem lesion involving the lateral spinothalamic system affects pain and temperature sensation on the contralateral side as well. A lesion of the primary sensory cortex affecting the system results in difficulties localizing pain, but not difficulties appreciating pain intensity. Pain can be characterized as sharp or dull, with sharp pain being mediated via specific thalamic nuclei and dull pain being mediated through multiple synaptic pathways. Lesions affecting the limbic system affect the emotional responses to pain, as well as somatic and visceral responses to pain. We assess deficits associated with lesions involving the lateral spinothalamic system by examining patients' responses to pinprick or their ability to assess hot and cold stimuli. We also look for the presence of other types of pain syndromes, such as referred pain, and a classic example here would be cardiac pain, which is perceived as chest or arm pain. Another pain syndrome is phantom pain, in which patients have persistent pain from an amputated body part. So that particular body part causes pain, and despite amputation of that body part, the patient continues to have a pain experience. The anterior lateral system also includes the anterior spinothalamic tract, which mediates diffuse touch. This too follows a 3 neuron organizational pattern. Similar to the lateral spinothalamic system for pain and temperature, there are projections bilaterally to the sensory cortex. Diffuse touch is a backup for the dorsal lemniscal system. Again, there are bilateral cortical projections. There are no obvious deficits present unless the spinal cord is severed completely. We can only assess diffuse touch when fine discriminative touch is not functioning. For particular interest to speech-language pathologists, we want to know about the sensory pathways for the head and face. Cranial nerve 5, the trigeminal nerve, innervates the head and face, and as its name implies, there are three branches. The maxillary, the ophthalmic, and mandibular. In addition to cranial nerve 5, sensation is also mediated by cranial nerve 7, the facial nerve, cranial nerve 9, glossopharyngeal, and cranial nerve 10, the vagus. The trigeminal sensory system is also a 3 neuron organizational system. The first order neuron is the semilunar ganglion, also known as the trigeminal ganglion. The second order neuron is in the brainstem, and there's a synapse on the chief sensory nucleus for discriminative touch, and on the trigeminal spinal tract nucleus for pain and temperature. Fibers cross at midline and ascend to the thalamus, and the third order neuron terminates in the post central gyrus Brodmann area 3, 1, 2. Again, this is a 3 neuron organizational system as depicted here, and you can also see the 3 branches of the trigeminal nerve. Discriminative touch from the head and face is mediated through the trigeminal ganglion. That is the first order neuron. The second order neuron is the chief sensory nucleus. There are crossed and uncrossed fibers which project to the thalamus, and the third order neurons of the thalamus project to the sensory cortex. Damage to the semilunar ganglion and the chief sensory nucleus result in a loss of discriminative touch on half of the face and head and the intraoral cavity on the ipsilateral side. Damage to one branch of cranial nerve 5 affects only a selected facial or intraoral area. We assess discriminative touch from the face and head using 2-point discrimination, tactile recognition of objects and letters, and passive jaw movement to determine proprioception. Proprioception is also mediated through the teeth, palate, and temporomandibular joint. The mesencephalic nucleus is comparable to the dorsal root ganglion but is located in the pons. This pathway controls the jaw reflex and regulation of bite force. Pain and temperature sensation is mediated through the trigeminal ganglion. The second order neuron is the spinal trigeminal nucleus, and this nucleus receives input from cranial nerve 7, the facial nerve 9, glossopharyngeal, and cranial nerve 10, the vagus, which mediate sensation from the ear, the tympanic membrane, pharynx, larynx, esophagus, and eustachian tube. Second order fibers cross midline and project to the thalamus, and then there are projections to the sensory cortex in the parietal lobe for this pathway as well. Some clinical correlates would include inflammation of the semilunar ganglion causing excruciating ipsilateral facial pain from herpes zoster or a trigeminal neuralgia. Assessment here is conducted through response to pinprick and light pinch, as well as response to hot and cold stimuli. Diffuse touch from the head and face is mediated through the trigeminal ganglion, spinal trigeminal nucleus, and chief sensory nucleus. And then there are crossed as well as uncrossed fibers which project to the thalamus and then onto the sensory cortex. Again, diffuse touch is a backup sensory system. This can only be assessed when the path for fine discrimination is not functioning. Damage to either trigeminal ascending tract results in incomplete anesthesia in the face and head. In addition to conscious proprioception, there is unconscious proprioception, which involves mediation of stretch afferents from limb muscles and joints to the cerebellum. This is a backup to conscious proprioception. There is ipsilateral input and output, and this unconscious proprioception is vital for acquisition of skilled motor activities. It is a 2-order neuronal system, so there are no projections directly to the cortex. Unconscious proprioception is mediated through 3 tracts: the ventral spinocerebellar tract, the dorsal spinocerebellar tract, and the cuneocerebellar tract. The ventral spinocerebellar tract mediates unconscious proprioception from the lower limbs and body axis. The dorsal spinocerebellar tract mediates unconscious proprioception from the lower and middle regions of the body, and cuneocerebellar tract mediates unconscious proprioception from the upper limbs and neck. Unconscious proprioception is a backup for the dorsal column medial lemniscal system. It is not always possible to relate the loss of kinesthetic and proprioception to this tract. This can be assessed using the Romberg test for unconscious proprioception, but we also know that this test is used to assess cerebellar functions related to conscious proprioception. I mentioned in earlier slides that another clinical application is neglect, which is a syndrome in which a patient fails to recognize one side of the body and the environmental space surrounding that side of the body in the absence of paralysis and visual problems. So this is an inability to be aware of stimuli, attend to stimuli, or recognize the significance of stimuli on the affected side. We most often see neglect in the setting of right hemisphere stroke, but do occasionally see neglect associated with left hemisphere CVA. So the right hemisphere patient would have a left-sided neglect, and the left hemisphere patient would have a right-sided neglect. Neglect may or may not co-occur with a visual field cut, such as a hononymous hemianopsia. The difference is that in neglect, the patient is ignoring one side of body and space and is not able to attend to that side of the body or that side of space. Neglect is seen in association with a lesion involving the somatic association cortex. There may also be other cognitive impairments as well as tactile agnosia. Neglect is manifested by an individual failing to eat food on one side of the plate. So for example, a right hemisphere patient may neglect the left side of the plate. Patients may begin reading at mid-sentence. They may omit details in drawing, and they may fail to recognize or identify a body part as one's own body part, and instead mistake their arm as a baby or another person in their hospital bed. These are some drawings illustrating neglect. So in the clock, the patient places all the numbers on the right side of the clock and neglects the left side of the page. Similarly, the drawing of the house is missing details on the left side, and the leaves and petals of the flower are only located on the right side of the drawing and are absent on the left side. And this is a picture of a patient who is neglecting her left side, so her gaze is deviated to the right, and her head is also actually slightly turned toward the right. We can assess neglect through a line bisection task in which a patient looks at a horizontal line on a page and is asked to draw a vertical line through this horizontal line, bisecting it evenly, and then we can measure how far from center the patient's vertical bisecting line has been drawn. We might ask patients to draw a clock or a flower to elicit evidence of neglect, or engage patients in a cancellation or identification task. So in these pictures, an individual was asked to circle the letter A, and you can see in the top portion of the drawing there are several letters that the patient failed to circle on the right side. In the lower drawing there are two letters which the patient failed to attend to on the left side. Other things that we might do to address neglect might be to have patients match printed letters, words, and numbers from a right to a left column. We might incorporate verbal cueing or use Penelope Meyer's concepts of edgeness and bookness to treat neglect. So she had patients trace the perimeter of a raised square or rectangle to locate objects within a particular space. And then the concept of bookness was that the patient would trace with their hand the perimeter of a closed and open book and then find the edge of the book to increase their attention to the neglected side to enable reading all the way to the beginning of a sentence.